Hello everyone and welcome to our YouTube channel Human Anatomy by Dr. Ankit. I am Dr. Ankit Khandelwal, Professor Anatomy, and today's session we are going to discuss all the high topics of anatomy which are very important for our upcoming Fmge 20th January 2024 exam. A big shout out to our subscribers and friends Shubham, Amazing World and Medico 159179 to suggest us that sir please take a session on these important topics as well. So let's start. In the previous video, we have discussed about these important topics. These are the top 10 topics which we figured out for our upcoming exam. In this session, we'll be discussing them in a bit of detail. Let us see which topics are we mainly going to cover. Here, today we are going to cover on the important vertebral levels. We are going to also talk on the superficial arteries which are palpable. Then joint types, I will post a link in the description where we have covered the topic of joints. Or you can go to our previous videos. We have done two videos on joints, one in Hindi, one in English. CT we can look at from the radio. Nerve injuries also we are going to look over here. Dermatomes as well. Apart from these images, then urethral rupture, larynx, pharynx and carpal tunnels are other important topics which we will cover whatever we can get hold on to it. So let's start this session, and it's going to be a concise session, not covering much in detail but covering all the important essential points from these important topics. First, let's start with the important vertebral levels. Normally we see हम देखते हैं एक दो क्वेश्चन आ ही जाते हैं इस टॉपिक से. So here we are going to see, here is a table taken up from the latest edition of Grace. For those who are interested in deeper understanding, can take a screenshot of this and do that in detail. For the time being, in today's discussion, we will be discussing these important vertebral levels and what are the important landmarks over here. So listen carefully. Let's start with the around C3, C4 vertebrae. Here we have the upper border of thyroid cartilage, and apart from this, we also have the carotid artery bifurcation also occurs over here. The carotid artery when it bifurcates. Okay, so you should know the carotid artery, commonly the common carotid artery bifurcate at the upper border of the thyroid cartilage, right? Around C6 we have the cricoid cartilage. So thyroid cartilage, then below thyroid comes the cricoid cartilage, and at this level we also have the ending of two important structures. This is the end of larynx and the end of pharynx. And apart from this, as the larynx and pharynx end over here, we have the beginning or the start of the trachea over here and the beginning of the esophagus over here. So remember these important points at the level of C6. Then if you come to the T2 level, there is a very important structure of a scapula related to it, which is the superior angle of a scapula. Superior angle of a scapula. And just below it at T3 level, we have the spine of a scapula. The spine of a scapula, right? We have the scapular spine and its origin, or you can say the root of a spine over here, to be more precise. Remember these two things. T4, T5 is very important because here you have the angle of Louis, or also known as the sternal angle, and a lot of structures are related to this sternal angle. What are those? We have the beginning and end of the arch of aorta over here. Around this, we also have the trachea bifurcation, right? We have the pulmonary trunk over here, and also the mediastinum is divided into superior and inferior mediastinum related to this sternal angle or the angle of Louis over here. Also the azygous vein, the arch of azygous vein also will enter into the SVC at this particular level. Okay, fine. Now around the level of T7, and the level of T7, what we have a very important structure over here that is again related to the scapula. And what is that? That is the inferior angle of a scapula. Okay, the inferior angle of a scapula over here, the superior angle was at T2 level. Now coming to T8, T10 and T12, we all know that these three levels are related to the diaphragm. The T8 level we have the entry of the IVC, the T10 level we have the entry of the esophagus, and the T12 level we have the entry of the aorta over here. Just to complete, along with these, along with the IVC, we have also the right phrenic nerve. Along with the esophagus, we have both the vagus nerve as well as the esophageal branches of the left gastric vessels, and along with the aorta passes the thoracic duct as well as the azygous vein. So do remember these important openings or the major openings of a very important topic, that is the diaphragm. Come to the L1, L3, L4, L5. Now these four are the important planes. These four are the important planes. The L1 or the lower L1 is around the transpyloric plane. L3 is at the subcostal plane where the rib cage actually ends. L4 is the highest level of iliac crest, that is the supracristal plane, and L5 is the transtubercular plane. Remember, these planes are also important for dividing abdomen into various quadrants. And apart from these, at the transpyloric plane, what else we have? At the transpyloric plane, we also have the origin of superior mesenteric artery. Remember, the celiac trunk normally origins around the T12. Around the L1, that is, we have the origin of SMA. Then we also have the formation of the portal vein over here. Then hilum of both the kidneys also lie over here. This is a very, very important plane. We also have the fundus of gallbladder over here. In adults particularly, the spinal cord will end over here. The spinal cord end over here where we have that conus medullaris. While in children and infants, it is the L3 where the spinal cord will end. So in children, it is the L3, and in adults, remember, it is around the level of L1. Okay, the transpyloric itself is saying we have the pyloric region of the stomach. So the D1, the first part of duodenum, will also be at this level. Coming to L3, which is the subcostal plane, a very important artery also rises from here, which is the inferior mesenteric artery. Apart from in children, the spinal cord ending is also occurring at this. Very important applied of this L4 supracristal plane is when we are doing the lumbar puncture. Okay, we take this as a bony landmark. Okay, L5 is the transtubercular plane. Now remember, one more you can add over here, that around L3, L4, we also have the location of the umbilicus, and it is at L4 only where the aorta ends, where the aorta, the abdominal aorta, it will bifurcate over here. And slightly below this at L5, the IVC actually begins. IVC begins over here. And just to add for your knowledge, at S2 what happens? At S2 we have the subarachnoid layer ends, or the arachnoid layer over here. Subarachnoid space is only up till S2. So these are important vertebral levels. Keep them in mind, very important topic. Next we come to the nerve injuries of both the upper and the lower limb. Very important high yield topic over here. A quick brief discussion over here. So to begin with, here we are seeing a couple of images. This is showing us which palsy. It's showing us the Erbs-Duchenne palsy. Erbs-Duchenne palsy over here, where there is undue separation of the neck and the shoulder. Okay, this is the mechanism of injury of Erbs palsy, where the upper trunk is involved, C5, C6 root value. Now, if you look at the Erbs-Duchenne palsy, mainly the important nerves which are involved over here can be remembered by the mnemonic SAM. SAM. S refers to the suprascapular nerve, A refers to the axillary nerve, and M refers to not the median, it is the musculocutaneous nerve. So remember that. Now coming to the Enda palsy, where the lower trunk is involved, we have C8T1, that is known as the clumcase palsy. Over here you can see the mechanism of injury. Now as the C8 and T1 are involved, what normally we see? We see clawing of hand. We see clawing of hand, which is shown in this image. And as the T1 is involved, remember, that can also lead to Horner syndrome. What is Horner syndrome? It is a sympathetic denervation of the head and neck, where you have ptosis and meiosis and anhidrosis, all that. So remember that clumcase and Erbs palsy, very important. Next we come over here with the image of the humerus and associated nerves over here. Okay, what are the nerves which are related directly to the humerus? So to begin with, we have over here the axillary nerve that is situated just around the surgical neck of humerus. Now this axillary nerve therefore can be injured in mainly 2-3 cases. If we have a fracture of surgical neck of humerus, if we have a shoulder dislocation, or if there is an improper intramuscular injection being placed over this deltoid region. Remember, axillary nerve supplies these two muscles, deltoid teres minor. Therefore, in axillary palsy, what we are going to see is loss of abduction of shoulder. Loss of abduction of shoulder. This is very important. Next, we come to the radial nerve over here. Radial nerve which passes through the radial groove. So, this radial nerve can be easily involved when there is a fracture mid-shaft of humerus. Remember that. Finally, we have the ulnar nerve which passes just behind the medial epicondyle. Therefore, in fractures of medial epicondyle, there might be injury to the ulnar nerve. Okay, remember these. Now, what will these nerve injuries present as? That we'll discuss later on. So, now coming to the 3 major nerves, the median nerve, the ulnar nerve, and the radial nerve. Now, what are the various tests which are conducted for median nerve injury? We have in median nerve, we look for the ape thumb deformity. What happens is the thumb is actually aligned with the other fingers. Normally, thumb is at a perpendicular degree. Then we have a pen test. We will see in the images. Then we have a pincer grasp and a pointing index. So, ये 3-4 tests which we should be knowing. Let's see one by one with images. So, here is what we are seeing is the ape thumb deformity. You can see the thumb over here is more close to the other fingers. It is sort of parallel. And this happens because as the median nerve is injured, so the thenar muscles are atrophied, except one thenar muscle, that is adductor pollicis, which is actually supplied by the ulnar nerve. So this remains functional and therefore it will adduct the thumb towards the other fingers. That is ape thumb deformity. Next we see over here as the pen test. What happens is we ask the patient to keep your hand on the table with the palm facing upward. ठीक है, palm ऊपर, और फिर हम we place a pen over here and we ask the patient to touch the tip of the pen with the help of a thumb. So in doing this action, there is adduction of the thumb. There is abduction of the thumb. That is done by the abductor pollicis brevis, and that is supplied by the median nerve. Now, if it is done, then it is fine. If it is not possible, if the patient is not able to abduct the thumb, we know it's a median nerve injury. So loss of touching the tip of pen, okay, with the abduction of thumb signifies median nerve injury. Pen test. Next we see over here as a abnormal pinch sign, also known as pincer grasp. Okay, so what happens over here, if we look at this figure, we ask the patient to make a circle with the help of an index finger and the thumb. Now in doing this, we see that the interphalangeal joint of the thumb is flexed and the DIP joint of the index finger is flexed. Now these two are actually done by flexor pollicis longus and the flexor digitorum profundus. Now these two are supplied by anterior interosseous nerve, which is actually nothing but a branch of median nerve. Now if the median nerve is injured, then obviously you can't flex the thumb of the interphalangeal joint of thumb and you can't flex the DIP joint of the index finger. So a condition like this results, over here, which is known as abnormal pinch sign. It is basically damage of the anterior interosseous nerve, which is actually a branch of the median nerve. And do also remember a famous question, that in supracondylar fracture humerus, it is the AIN, anterior interosseous nerve, which is mainly damaged over here. That is another test. And finally, remember this image over here. Here, you have to look at these two images first of all. If you see an image like this can be two things. Either it's ulnar nerve injury or it's a median nerve injury. Okay. If we take first of all as a median nerve injury, then what happens? This will only occur when you ask the patient to make a fist. Okay. Normal hand is like this. If you ask the patient to make a fist, only these two fingers are flexed. That is also known as hand of benediction, right? That is seen in median nerve injury when you ask the patient to make a fist. It's also known as a pointing index. But when the patient comes with the hand at rest like this only, that is ulnar clawing, it is seen in ulnar nerve injury. So these two differences. So at rest, if the image comes like this, it is ulnar nerve injury. While during making a fist, if the image comes like this, it is a sign of benediction or hand of benediction, median nerve injury. And we also know that the radial nerve, we have the wrist drop. Why? Because radial nerve, when it gives off the posterior interosseous nerve, they supply all the extensors of forearm. These are all the extensors of forearm. So if they are paralyzed, the patient is not able to extend the wrist. So wrist will be dropped like this. That is known as wrist drop. We will see more. So remember these few tests in median nerve injury, revise them. Okay, here is another image showing us a median nerve injury where the thenar muscles, these are all the muscles of the thumb known as thenar muscles, they are atrophied over here. Okay, next we move to the ulnar nerve. Ulnar nerve, first of all, you should know it supplies basically all the muscles of the hand except the thenar muscles and first and second lumbricals. So what does ulnar nerve supply? It supplies the hypothenar muscles, the third, fourth lumbricals, and all the interossei, P and DR, palmar and dorsal interossei. So what are the various tests which we will look over here? The book test, the Froment test, they are sort of similar. Then we have a Carden-Egawa test. We'll see in the images. So if we start from here, there is a book test over here. This is the book test. If you ask the patient to hold the book like this, and you ask the patient ki I'm going to pull it, you resist my pulling force. So normally this will happen. If you look at the left thumb of the patient, normally this happens with the usage of the adductor pollicis, because adductor pollicis, as we know, is supplied by the ulnar nerve. So this is normal scenario. But on the right side, if the adductor pollicis is non-functional due to ulnar nerve injury, what will happen? The flexor pollicis longus is going to take the role of adductor pollicis, and they will be bending of the thumb over here, as you can see. So what happens? In place of adductor pollicis, the FPL takes over, because ulnar nerve is injured. So now FPL, which is supplied by median nerve, will take the role. That is known as book test, and sort of similar is the Froment's test. Again, you can here see the normal scenario over here where the adductor pollicis is working. On the right side, in place of adductor pollicis, it is the flexor pollicis longus that is working. Remember, FPL supplied by the anterior interosseous nerve branch of the median nerve. Next, we see over here the card and the GABA test. We all know that we have famous mnemonics, pad and dab. Palmar interossei do adduction of fingers, dorsal interossei do abduction of fingers. This is adduction of finger and this is abduction of finger. So, to test the palmar interossei, you do a card test. You place a card in between the two fingers and you ask the patient that I am going to pull it. मैं इसे खींच रहा हूँ, इसको resist करो, try to resist it. If the patient is able to resist palmar interossei, fine. If you can easily slide the card away between the fingers, then the palmar interossei are probably not working. That is known as a card test. And similar way for dorsal interossei, we have the IGAVAS test. Okay, so remember these two tests over here. Next, we come to the radial nerve. Radial nerve supplies basically the triceps, the posterior arm muscles and the posterior forearm muscles. So remember, in a radial nerve injury, what we are going to see? We are going to see the wrist drop and also the finger drop. Now, what are these two things? This is wrist drop, right? And this is finger drop. When you can't extend the fingers, it is finger drop. It is finger drop. You can't extend the fingers. This is wrist drop. So normally in radial nerve injury, what we see is, we see a combination of a wrist drop and a finger drop. But if only posterior interosseous nerve, PIN over here refers to posterior interosseous nerve, is damaged, then we are only going to see the finger drop. Why not wrist drop? Because the extensors of the wrist, basically the ECRL, is supplied by the radial nerve. Another difference over here is that as PIN is a pure motor nerve, there will be no sensory loss over here. But as radial nerve also gives off the superficial branch of radial nerve, therefore there will be also be sensory loss in radial nerve palsy. Where exactly? Sensory loss will be there between the thumb and the index finger on the dorsal aspect over here. This is the position where normally sensory loss will be there. So remember that difference. Okay, so this is a wrist drop over here. Okay, so remember these few nerves and the important parts. Here is the image showing us 2-3 very important things. Let us see what are they. Over here, focus on the highlighted ones, the median nerve. Look at the radial artery and just remember that it is the radial artery is lying just lateral to the FCR. Remember the mnemonic ALT, where A is artery, is L lateral to tendon. Now which tendon? FCR. Which artery? Radial artery. If you take this mnemonic and you apply on the medial aspect, same thing happens. Ulnar artery, tendon is FCU. So in the medial aspect, the ulnar artery over here will be lying lateral to tendon of flexor carpi ulnaris. Okay, so remember that image, and the location of median nerve at the midline, at the midpoint over here, or you can say in the center of the wrist. Next image over here shows us the location or the branching of the radial nerve into a deep branch and a superficial branch, which is sensory, and deep branch, that is known as PIN. Okay, it is known as PIN. It is a pure motor and it leads to finger drop. While radial nerve injury will lead to wrist drop, finger drop and sensory loss in the dorsal aspect between the thumb and the index finger. Remember that point. Now we come to some of the carpals over here. Carpals, we should be knowing the mnemonic. The mnemonic is from lateral to medial. Mnemonic is the she looks too pretty, try to catch her. But remember that is from lateral to medial. First the proximal row and then we have the distal row. Here remember the she looks too pretty, the T over here refers to triquetral. Right over here, triquetrum or triquetral. Tri means third one. While these TT are trapezium and trapezoid. Trapezium and trapezoid. Trapezium ZI comes first, then trapezoid ZO. Remember that difference as well. Now coming to the lower limb nerves and the injuries as well. Now see, there are various nerves in the lower limb. Let us see the important parts, what happens when they are injured. Iliohypogastric nerve, remember, is basically a sensory nerve, and that actually supplies the region of the suprapubic area. So in case of abdominal surgery, this nerve can be damaged. There can be some paresthesia around the pubic region. Point number 1. Second is genitofemoral nerve, that also can be injured in laparoscopic surgeries, in hernia surgeries. Okay. Then you have the lateral femoral cutaneous nerve of thigh, root value L2, L3. That you remember, for those who are doing PYQs, there is a meningia paresthetica over here, right? And this lateral femoral cutaneous nerve can be compressed due to tight clothing or obese person, or when there is a hypertrophy of the anterior thigh muscles, because this nerve lies very close to the ASIS, anterior superior iliac spine or iliac crest. Next with the obturator nerve, it is a nerve of the medial compartment of the thigh, and it passes through the lateral pelvic wall. So during pelvic surgeries, this obturator nerve can be damaged. So you will have problem in the medial compartment of thigh. Next we have the femoral nerve. Femoral nerve can be damaged when there is pelvic fractures, pubic fractures over here, and it is lying around, you can say, the lateral part of the inguinal ligament. It supplies the anterior thigh muscles. Next, we have the sciatic nerve. Sciatic nerve, remember, passes just beneath the piriformis muscle. Therefore, any problem in the piriformis muscle or piriformis entrapment syndrome can lead to compression of sciatic nerve, or if there is a prolapse of the intervertebral disc. Next, we have the common peroneal nerve, which is one of the most common nerves in the lower limb to be damaged. And that actually wraps around the fibular neck. So, in cases of fibular neck fractures or injury on the lateral part of the knee, this common peroneal nerve can be damaged. Next, we have the tibial nerve, which actually supplies the posterior leg as well as the sole of foot. Now, as this nerve passes and the popliteal fossa, so a common condition like a Baker's cyst can compress this tibial nerve. So, remember these few nerves in the lower limb, and let us see some of the images over here. Here is a whole dermatome, and particularly to these two images showing us the sole of foot and the dorsum of the foot. Remember the common questions that have come a lot of number of times. The deep fibular nerve supplies between the first interdigital cleft sensory. And over here you have the medial and the lateral plantar nerve supplying the medial 2/3 and the lateral 1/3 of the sole of foot. Remember, these two are branches of which nerve? They are branches of tibial nerve. We will see more. Moving ahead, this image we have what? We have the muscle piriformis and the sciatic nerve which is running just below it. Okay, so remember, sciatic nerve is actually combination of tibial and common peroneal, and that can be entrapped in the piriformis. Next, the same image over here, and here is the surface marking of the sciatic nerve, very important. Here we have to take few important bony landmarks like posterior superior iliac spine around S2, where we learn that end of subarachnoid layer or the arachnoid layer ends over here, and the subarachnoid space ends over here. That can be also seen around the sacral dimple over here. And we have another point known as ischial tuberosity, where normally when we sit on a hard surface, the bone that touches the surface is ischial tuberosity. On the lateral side, we have bony, that is a projection known as greater trochanter. So, if we take the midpoint of these two bony landmarks, that will be say point A over here, and if we take the midpoint of these two bony landmarks, let us say point B over here, and if we join these two A and B, that gives us an idea of where exactly the sciatic nerve is lying. Here we have the safe area for the IM injection on the gluteal region. Okay, it's a lateral view having anterior and the posterior aspect on these two areas. Next, we come to the Trendelenburg test over here, or Trendelenburg sign over here. This is actually showing us a normal scenario where the right foot is on the ground, so the left foot is taking off the ground, and the right sided, these two muscles are gluteus medius and minimus. They are contracting and they are pulling the pelvis towards the right side. That is normal. But if suppose the gluteus medius minimus, they are injured, or their nerve supply, that is the superior gluteal nerve, is paralyzed or injured, then these muscles are paralyzed, right? And these muscles are basically abductors of hip. So, if the superior gluteal nerve is damaged or these muscles are not working, then what will happen is that when you take the left foot off the ground, the left side of pelvis drops down. So, remember, it's a normal side of pelvis that is dropping down in Trendelenburg test. That is very, very important for understanding, and a very important question comes from here. Next, we have this flow chart for the femoral nerve. Here also again we are showing the gluteus medius gate, that is known as Wedling gate, and the gluteus maximus lurch is known as extensor lurch, because gluteus maximus, remember, is the chief extensor of the hip joint. It is the chief extensor of the hip joint, right? Okay, next we move over here to look at the popliteal fossa. This is an image for the popliteal fossa, and you can very well see the tibial nerve lying over here in the popliteal fossa. And this tibial nerve supplies the calf, that is the posterior leg, and the sole of foot. And therefore, if you have a Baker's cyst sort of situation over here, it might compress the tibial nerve. And remember, when the tibial nerve is compressed, it basically leads to loss of plantar flexion. Okay, you can remember this by the mnemonic TIP, which we will discuss later on. But TIP over here refers to the tibial nerve. The muscles are basically inverters and plantar flexion. Okay, and remember also that this tibial nerve can also be damaged in tarsal tunnel syndrome, that is around the flexor retinaculum of the ankle. Remember, we have a carpal tunnel syndrome for the wrist, median nerve. Similarly, we have a tarsal tunnel syndrome, that is for the tibial nerve, right? Okay, let's move on to see over here the common peroneal nerve, where it is winding around the fibular neck, and it divides into deep peroneal and superficial peroneal nerve. Right? Remember, the deep peroneal supplies the anterior leg and the superficial supplies the lateral leg. So, as we know that this is one of the most common nerves to be damaged in lower limb. So, when CPN is damaged, DPN and SPN, DPN is deep peroneal nerve and SPN is superficial peroneal nerve. They are also damaged. So the DPN is damaged, that leads to very important finding known as foot drop. Like wrist drop, we have foot drop. You can't dorsiflex the foot. That is foot drop. And also there is loss of eversion because the peroneus longus and peroneus brevis are supplied by the superficial nerve. They are the everters. So there will be loss of eversion as well. Very important point over here. Okay, now let's move to see an image to see the normal lathi charge, we can say, situation when the injury might happen over here in the fibula, at the lateral part of the knee, in the common peroneal nerve area, that can lead to CPN palsy. Okay, here is a mnemonic which I already discussed with you. The TIP, the tibial nerve, is for inversion of the foot and also for the plantar flexion, and the PED, remember, with the peroneal nerves are the everters and the dorsiflexion. So that will help you. Here is a flexor retinaculum being shown to you, and that is a tarsal tunnel, and through which passes the tibial nerve. So tibial nerve is very close to it, and it will pass somewhere around over here to go to the sole of foot, dividing into medial and the lateral plantar nerve. So tibial nerve can be damaged in tarsal tunnel. Next, one more mnemonic for you guys is this femoral nerve, FEM. Femoral F will refer to the flexor of the hip. So femoral nerve is flexor of the hip. Which muscles? Iliacus, your rectus femoris. E refers to the extension of the leg, because femoral nerve supplies the anterior thigh muscles, quadriceps femoris, they are extensors of the leg. And M over refers to the medial leg. Why? Because saphenous nerve, which is a branch of the femoral nerve, it supplies cutaneous, not motor, but this part is what? It is cutaneous to the medial leg and the medial border of the foot as well. So remember that femoral mnemonic. Here you can see this is the foot over here, basically the sole of foot region. And you can see how the tibial nerve is dividing into medial and the lateral plantar nerve, and then the giving of all the branches to the muscles as well as the skin over here. Sensory supply, remember medial plantar nerve supplies the medial 2/3 of the sole of foot, and the lateral plantar nerve for the lateral 1/3 of the sole of foot. Okay. And here again the deep peroneal nerve over here, which is ending at the first interdigital cleft. Again what? It is sensory supply giving over here, while it is motor to which area? It is motor to anterior leg, and that injury to DPN leads to foot drop. Okay. Here the name of tarsals, there are 7 tarsals. Remember the talus over here, right? The talus over here, that forms the ankle joint. Below talus we have the calcaneus, that forms the heel. In front of talus we have the cuboid bone, and which joint are they forming? They are forming the ball and socket. In front of talus we have the navicular, not the cuboid, we have a navicular. So talus, navicular, they are forming the ball and socket. Calcaneum and cuboid, CC joint, is the saddle variety. Then in front of navicular we have the 3 cuneiforms, the medial, the intermediate and the lateral cuneiform. So remember to identify the tarsals and the carpals. So moving from here, now we come to the dermatomes. So all those who have subscribed to Ellen Next app, I have their videos describing all the dermatomes in detail. But this is an image which I found perfect for you to understand the dermatomes. Look at the positioning of the upper limb and the lower limb, and the brachial plexus and the lumbar plexus supplying the upper and the lower limbs. Remember over here, as written already, the C1 has no sensory supply, Okay, here are the images of the dermatomes. I advise you to kindly take a screenshot if you want to see them in detail. Next, after this topic, we come to another topic, that is the superficial arteries, the palpable arteries. Remember, there are around 9 arteries or 9 areas in the body where we can palpate the arteries. To begin with, we have over here the superficial temporal artery. You can palpate it right in front of the tragus of the ear. It's a branch of the external carotid artery. Then the facial artery. It can be palpated at the lower border of mandible, just in front of masseter muscle. Facial artery. Then carotid artery is obviously felt over here, okay, in the carotid triangle around say C4, C5 area. Then you have the brachial artery where you take BP. Brachial artery is right in front of the elbow or in the cubital fossa. Remember MBBR from medial to lateral, MBBR, mnemonic. M is median nerve, then brachial artery, then biceps. So first is brachial artery, then biceps. Then radial artery, we already know it's lying lateral to which tendon? FCR, flexor carpi radialis. Then femoral artery, the mid-inguinal point. Then popliteal artery in the popliteal fossa. Posterolateral artery, we have seen the flexor retinaculum of the ankle, where we saw the tibial nerve, tarsal tunnel syndrome. Just around there, we have the posterolateral artery. And then in the dorsum of the foot, we have the dorsalis pedis between first and second metatarsal. I will show an image of all of these arteries. Just identify which arteries are we talking of over here. So, I hope we can easily answer. There is a carotid pulsation over here, right? And coming to figure number B, here the brachial artery is being palpated. Okay. Option number C, easily recognizable, is the radial artery being palpated over here. Option number D, okay, there is a thigh region over here, and this is the femoral artery that is being palpated. Then over here, popliteal fossa, so artery is popliteal artery, right? Here you can very well see dorsalis pedis. It's actually continuation of which artery? It's continuation of anterior tibial artery, and very important for peripheral vascular diseases to identify them. And finally over here, there is a medial malleolus, and this artery that runs around over here, that is a posterior tibial artery. It's a posterior tibial artery. Okay, so these are the important arteries that you should know, right? So that's all. I wanted to keep it short and crisp and concise, and these are important topics. All the best for your exams, and that's all from my side. Keep on subscribing to my channel, and if you like the video, do share and subscribe to it. Thank you.